Distinguished guests, colleagues, and friends, good afternoon and welcome to this exciting session on the topic of unlocking global health success through inclusivity, why inclusivity needs to be at the core of the global health goals, including considerations for gender. It's nice to see so many of you here in the room at this late stage of the summit. My name is Binod Mohanty. I'm a senior policy advisor on global health and infectious diseases in the German Federal Ministry of Health. And I'm honored to welcome all of you here to today's session at the World Health Summit 2024. In fact, like I said, one of the final sessions of this summit. Actually, welcome everyone here in the room and also online. The German Federal Ministry of Health is a long-standing partner of the World Health Summit and a strong supporter of this forum, promoting networking, collaboration, and open dialogue. Today's session will delve into why addressing inclusivity and gender diversity are important concepts and approaches for improving health outcomes, and should therefore be central to global health strategies. Inclusivity in global health refers to the practice of involving all individuals, communities, and countries in the creation and implementation of health strategies. It ensures that policies are equitable and accessible, especially to marginalized or vulnerable populations. The importance of these concepts is starkly illustrated in the context of HIV/AIDS and the AIDS response. In many parts of the world, new HIV infections occur predominantly in men who have sex with men, transgender and gender diverse people, sex workers, people who inject drugs, or prisoners, often marginalized or even criminalized groups. But we have also seen in recent years that these concepts and approaches are being increasingly challenged and questioned and pushed back in global discussions and negotiations. In this session, we will therefore try to unpack some of these concepts and maybe even explore options of how we can get out of this deadlock. Therefore, without further ado, let me introduce you to the esteemed panel. And I will start with the only man on this panel, Friedel Dalsap, who is a Namibian activist who successfully challenged the colonial anti-homosexuality law and had it struck down by the High Court in June 2024. Following his HIV diagnosis in 1999, Friedel began campaigning for the inclusion of marginalized populations and ensuring their access to HIV treatment and services through legal and policy frameworks. Welcome, Friedel, and thank you for your participation.
Thank you.
I'm also glad to welcome Christine Stegling, who is the Deputy Executive Director of Policy, Advocacy and Knowledge at the Joint United Nations Program on HIV/AIDS, UNAIDS, and an Assistant Secretary General to the United Nations. Her policy and advocacy work at global, regional, and country levels has helped increase access to HIV prevention and treatment, expanded sexual and reproductive health and rights, and supported marginalized people through community-based programs. Welcome, Christine. I'm also very happy that Dr. Tina Rudolph, who is a physician and medical ethicist from Thuringia, is part of this panel, Thuringia in Germany. She's a member of the Social Democratic Party, SPD, here in Germany, and she's also a member of the 20th German Parliament, the Deutsche Bundestag. She's part of the Parliamentary Health Committee as well as the Subcommittee on Global Health. Welcome, Dr. Rudolph. And last but not least, let me also introduce our moderator today, who is Dr. Pascal Alloté, the director of WHO's Department of Sexual and Reproductive Health, including the Special Program of Research Development and Research Training in Human Reproduction, HRP. Her recent work includes challenging the boundaries of global health, advocating for accountability in the decolonization of global health and international development, and expanding opportunities to diversify the voices of contributors to global debates and decision-making. She's kindly agreed to moderate the session. So without further ado, over to you, Pascal.
I'll say again, I'm always happy to receive the applause in the beginning. So if I bomb, at least I can say you clap for me. Okay, so this is the last formal session before the closing. Can I get a gauge of people's energy levels? 50% and under, hands up. Okay. 80%? 100%?
One.
Well, okay, excellent. Okay, so I have to say I'm tired. I'm exhausted, and I'm tired of this topic. I'm tired that in 2024 we are still having to have discussions about inclusivity. And it matters at the grassroots level, it matters in the UN spaces. Now, countries, all of our countries have agreed through the SDGs, SDG 5, which is gender equality, SDG 1, poverty, SDG 3, health and well-being, SDG 4, quality education, SDG 8, decent work and economic growth, SDG 10, reduced inequalities, 11, sustainable cities and communities, SDG 16, peace, justice, and social institutions, SDG 17, partnerships for the goals. These discussions have been had already and have been agreed on. They were the basis for the MDGs, and yet we are still having to worry about what's going to happen in a few weeks from now in some countries' democratic process, and in a whole range of other countries as well. We are still having this discussion. So, good afternoon, esteemed colleagues and global health champions. I'm honored to open up this discussion on gender inclusivity in global health, a discussion that is not only timely, but essential for achieving our broad health and development goals. In this workshop, and I hope I asked about your energy, so you need to make sure that you can put your hands up, start writing down your questions. In this workshop, we want to explore how gender inclusivity, framed within the principles of human rights and the Sustainable Development Goals, must be central to any global health strategy. The SDGs, which serve as our global roadmap for a better and more equitable world, have made it clear no one must be left behind. This commitment is not just a rhetorical flourish. It is a fundamental principle of global progress. To truly leave no one behind, we must recognize and address the gender disparities and exclusions that continue to undermine global health efforts. So just for some general definitions, I think are useful. When we talk about gender, we're talking about socially constructed roles, expectations, and norms that manifest in terms of different attitudes, beliefs, division of labor, and in hierarchies of power, distribution of resources, and status. In most societies, gender roles, expectations, and norms privilege men over women, cisgender over transgender identities, and heterosexuals over homosexuals. Gender identity is the deeply felt internal and individual experience of gender roles, norms, and expectations that may or may not correspond with their designated biological sex at birth. Gender sensitive refers to interventions, activities that recognize differences due to gender norms, roles, and responsibilities, but not necessarily take any action to address these differences. So an example may be men's involvement in women's use of contraception, and this is recognized, but there is no action taken to address their roles and responsibilities, and men are reached out to be a part of discussions as gatekeepers. Gender responsive. These are policies or programs or interventions that not only recognize harmful norms, roles, and power relations, but work to reduce the harmful effects of these. An example of this might be policies that give paternity benefits to encourage men to participate in child or infant care, in addition to maternity benefits. Gender transformative refers to interventions and activities that address the root causes of unequal gender power relations by challenging harmful norms, empowering women, fostering equal decision-making, and power sharing in intimate relationships within families and in communities. And an example are programs that mobilize communities to change their attitudes towards power sharing and equitable decision-making to improve health outcomes. So what do we mean by gender inclusivity in the context of global health? Gender inclusivity not just recognizes the differences between men and women. It's about understanding the complex spectrum of gender identities and social roles that shape how individuals experience health, access health care, and are treated within health systems. It demands that we challenge the power structures that drive inequality and ensure that everyone, regardless of gender identity, sexual orientation, or socioeconomic status, has equal access to health services. And gender equality is equality of opportunities to access and control social, economic, and political resources, including protections under the law, such as health services, education, and voting rights. The reality of gender inequalities is stark. Disparities continue to persist across all areas of health, whether it's the disproportionate impact of HIV on women in sub-Saharan Africa, the marginalization of transgender individuals in healthcare systems, or the lack of access to sexual and reproductive health services for marginalized groups marginalized by disability, indigeneity, ethnicity, migration, and the list goes on. We see over and over that vulnerability is gendered. Gender is a primary lens through which we must examine inequality in health. So why is this a red flag? Why is gender a red flag? Why do I walk into a room in WHO and my colleagues go, oh no, it's the gender person again? So why has gender inclusivity become such a red flag in today's global discourse? At its core, gender inclusivity challenges power. Guess what? When we started fighting for women's equality and women's empowerment, that's going to change something. We're here and we're not going anywhere. So that means not just women being more present, but changing the way things are done. We didn't fight for equality to become men. We fought for equality for power within this space, and we will bring it in the way that we want to bring it. We're not going anywhere. Okay? So it calls into question traditional norms about masculinity, femininity, sexuality, and control over bodies. As we push for more inclusive health policies, we are also challenging deeply entrenched social, cultural, and political hierarchies. Gender rights, especially when framed in the context of broader human rights, threaten systems that benefit those in power. We are also witnessing the rise of an anti-rights movement, which frames the advancement of gender and sexual rights as a threat to traditional values. This movement, often led by political and religious actors, has mobilized against progress in women's rights, LGBTQI+ rights, and sexual and reproductive health and rights. In some regions, we have seen abortion rights rolled back, comprehensive sexuality education vilified, and even health data on marginalized groups suppressed. This growing backlash is not just theoretical. It is having a tangible impact on global health negotiations. In some international forums, we see terms like gender being stripped from agreements. In discussions of sexual and reproductive health, these are becoming more polarized. Sex workers are not allowed to have a seat at the table, and other key groups are excluded from critical policies. This undermines the very ethos of the SDGs and the commitment to leave no one behind. Let's be clear, Gender inclusivity is not a side issue or a luxury for wealthier countries to address when convenient. It is a fundamental human rights issue. The right to health is enshrined in international human rights law, and it cannot be realized unless we address the systematic and systemic inequalities that keep certain groups from accessing health services. The WHO Constitution, along with international treaties like the Universal Declaration of Human Rights, makes it explicit. Every person has the right to the highest attainable standard of health without discrimination based on gender, sexual orientation, or identity. This principle is non-negotiable. To exclude anyone from healthcare on the basis of gender is a violation of their fundamental human rights. But human rights go beyond access. It is not enough to ensure that services are available. We must also guarantee that these services are equitable, respectful, and free from discrimination. In too many parts of the world, marginalized groups face stigma, legal barriers, and violence that prevent them from seeking the care they need. This is not just a failure of health systems, it is a failure of our global commitment to justice and dignity for all. I will be quiet now because I do have an amazing panel of experts who are going to really go through and provide us with some really concrete examples of how, or to open up the discussion for us to deliberate on further. So I will start off with you, Christine, if that is okay. Tell us.
Thank you, Pascal. I think you get a round of applause for a good starting speech. You asked me to, in my first reflection, really talk about the evidence that we have that stigma and discrimination and restrictive laws have on access to HIV and health services. Obviously, I come from the Joint Program on AIDS, so my perspective is always centered around HIV. So I will do that. But let me first thank you, but also thank the Federal Ministry of Health for hosting this event here. And as one of you came to me before the talk and said, I'm so glad there is a session like this, and there's a session that talks about HIV. There aren't many, or maybe none, in this forum at the moment. So I think hopefully we're not just all the converted, but there is obviously need to have those conversations. So thank you for providing that space. So let me just talk about the evidence. And I feel like you started off by saying, are we tired of having this conversation? I think many of us who've been doing this work for a long time, yes, we're tired, but we also know that some of the work takes a long time. I know Frida will talk about his amazing or difficult and challenging but ultimately successful journey in Namibia. But many of us know that the work that is required to change social norms, change behavior, but importantly change laws and policies is a long-term game. And that's why sometimes I feel like we are having the same conversation, because the impact, it takes long to get there. I was myself very delighted when we changed the law, when the legal challenge in Botswana was successful only a year or two ago, but I started this 25 years ago. So it takes a long, long time, and therefore I think it's often hard to show the impact it has when we decriminalize or when we change laws and policies. So let me talk a little bit about the evidence. And we now have more academic research and evidence that really gives meaning to what communities have been telling us a long, long time before that. And I think it kind of shows us how important it is that we listen to communities in the first place, that we don't have to wait for what we call the hard evidence to be available when communities come to us and say, gender discrimination, stigma and discrimination are keeping us away from health services. We should have listened even before we had a study that told us so. But we have evidence now. So just a few data points I think that are important. So we know that people living with HIV who experience discrimination in recent data sets that we have are about 2.5 times less likely to go into healthcare facilities. We know from a study that was done in sub-Saharan Africa that about almost 30% of transgender women told us that they were too scared to use healthcare services, all giving meaning to what you have already talked about. We know that sex workers in countries that criminalize sex work are 7 times more likely to be living with HIV than those in countries with partial legislation. We also know that HIV-related stigma intersects with gender inequalities and damaging gender norms to drive mistreatment and abuse of women living with HIV in health services, particularly, and there are really terrifying examples, I have to say, when it comes to sexual and reproductive health and rights of women living with HIV. There's been a review of studies on gender equality and women's empowerment in Africa, and it found that as many as 1 in 3 women living with HIV reported experiencing at least one form of discrimination related to their sexual and reproductive health and reproductive rights in a healthcare setting within the past 12 months. And that was done by the African Union in 2022. So all of this, and there are many, many more data points, but I think it's enough to show us and to remind us that these kinds of discriminations that people experience in healthcare setting impact on people's health and well-being. But for example, in the case of women, when they are experiencing those kinds of discrimination, it also impacts on the healthcare of their family. We know that women living with HIV who are not trusting in the healthcare setting as a woman living with HIV are also less likely to come with their children, to get their children tested for HIV. And therefore, we are losing contact with people in the healthcare setting because of that. We also know, and I'm sure Friedel will talk a lot more about that where same-sex sexual activity is criminalized, men who have sex with men are 5 times more likely to be living with HIV. And this goes up to 12 times more likely when there has been a recent prosecution. Often we hear when we're starting this conversation of legal changes, then people say, well, there's a law, but it has never been implemented, or we haven't seen prosecution. So yes, we can see a difference between prosecutions and people knowing that there is real danger to them. But there is also a narrative that spins or goes through the community and also through law enforcement officers, even if there is no prosecution. There is bribery, there's all sorts of things that impact the community to trust the health system. So back in 2021, when we were, and I say this with a little bit of trepidation because we're about to go and do the same thing again, but UNAIDS, the joint program, is responsible for setting up the Global AIDS strategy, the strategy that tells all of us, all the partners, what we want to reach, what our targets are, but also how we get there. And because we're always having such a hard time, even in the HIV space, to make an argument about enabling environment, structural drivers to health, we did actually, when we did the 2021 strategy, we partnered with Avenir Health to model the impact of social enablers, so criminal law, stigma and discrimination, violence and gender inequalities, and ask them to model what happens when we do not address these barriers. And because sometimes, especially people who fund programs and governments will only be talking to you when they see the economic impact or the human impact of this. So the modeling showed us then that we would have 2.5 million more people acquiring HIV by 2030, and that 1.7 million additional people would die of AIDS-related illnesses if we're not addressing what we call the social enablers. So that's an important conversation, especially at a conversation that many of the conversations I have been in, or the panels that I have been I have participated in this conference, is about sustainability. How do we sustain programs, health programs and HIV programs into the future? So when we want to do that, not only do we need to address do we need to fund and apply ourselves to the biomedical interventions, but we know these other issues that are often seen as not so important, pushing for gender equality, ensuring that we leave no one behind, need to be funded and addressed in the very same way, because they have a real impact on how many people will be living with HIV and how many people are infected with HIV. So my last point will be about and making a point about integration, because a lot of you in this room probably are part of conversations where we're looking at how we're integrating what we often refer to in these spaces as vertical programs into broader programs. So the Global Network of People Living with HIV last year looked at experiences of stigma and discrimination when accessing HIV-specific health services versus non-HIV services. So for people living with HIV who often, obviously, also access other health services, and looked at the rates of stigma and discrimination. And they were almost twice as high in non-HIV services for people living with HIV. So that shows you that we have come a long way to addressing some of these structural drivers or barriers in health settings for people living with HIV. But when we integrate, we might lose a lot of that that work. So something for all of us to keep in mind as we're thinking about how do we continuously integrate services that we all built over the last 20 years into broader health systems. I'll leave it at that. I know there's a lot more interesting to say about the backlash that we're all experiencing and why that is. You started the conversation, but I think it would be good. I thought it was important that we also frame the conversation of what the evidence tells us, what the impact is at a very practical level. I'll leave it at that for now.
Thank you very much, Christine. If you have questions for Christine, please note them down. When we finish the initial panel discussion, I'll open it up for questions. Friedel.
Yes, thank you. Thank you, Dr. Pascal, and thank you to the organizers for inviting me here. So 3 years ago, my job title would be different. I would probably be something like a public health advocate or something, but currently I'm a safety and security coordinator for the LGBT community in Namibia. And I think that kind of talks about how the situation has changed and how legal wins don't necessarily translate into immediate improvement of the situation for minorities, especially marginalized minorities in Africa, where I find myself. And so, just as a background, in June of this year, I won a high court case after about 30 years of advocacy. And sometimes when I was thinking about this topic, I was thinking that maybe we were even more successful in getting into the national strategic framework for HIV in the country, having written into it. So as a 25-year-old who had just been diagnosed with HIV, when I first came to the advocacy table, government officials would say, "We don't have them here. There are no gays in Namibia." 25 years later, and even before I won my case, we have now gay men, other men who have sex with men in the national strategic framework. We have sex workers written in, and newly we have people who use drugs and people who inject drugs written into the national strategic framework. However, 2 years ago I had to change the direction of my job, because what we found was that communities were more at risk, and even though services were available, and even though we were advocating to make them more friendly, more population competent, we were successful in having the government put a budget to key populations programming in the country. We found that people were not feeling so safe. We found that people were getting attacked more and more in their homes, and that translated to people not going to health services, people not adhering to their treatment, and that individual health outcomes for people were not as good as we wanted it to be. And so my talk today is really about the impact of legal wins We do find that, and what I was thinking, should we then stop? And the answer is no. We need to keep on litigating, but I think we also need to have a three-pronged approach, which we are taking in Namibia in terms of litigating. So litigation has always been the last resort. We have a big chunk of work in community engagement. We find that even though there are legal wins and the law changes, even if there are policy wins and we are able to get national strategic frameworks to be inclusive, when communities don't understand LGBT people, they don't understand the life experiences of sex workers, of trans women, people are always unsafe in their homes. They are unsafe, they can go to the shop, they can go to public health centers, etc. And so we need to kind of make sure that we are always able to speak to communities so that they understand. We speak to religious leaders, because that's where the stigma comes from the way that we see religion. We need to speak to traditional leaders, because what we get as LGBT in Africa is that this is a Western import. And so when we don't really put our energies towards community engagement and we leave it out, the successes that we may have in terms of legal wins or policy wins do not translate into the maximum success that it is supposed to be. But the legal win that we had in Namibia is still a legal win. It means now that homophobes and transphobes cannot hold on to an old colonial apartheid law to say, because of this law, I can go on and discriminate against you. I can exclude you from service. I can exclude you from banking. I can exclude you from getting the same respectful treatment in a healthcare center. And so we've kind of seen that when we are now speaking to community leaders, when we're speaking to healthcare workers, when we're speaking to police, that is now no longer a ledge that they can hold on to. They have to speak to us as Namibian citizens with equal rights, because as part of the constitutional challenge, the verdict has been quite clear that that discrimination on the basis of sexual orientation and gender identity is unconstitutional and invalid. What we have found, however, is that even though we won, and so I must just say that my win was not the first one. It has been successive. And so a couple of years ago, Mercedes van Klute, who is a trans woman, was picked up at a local KFC, bundled into a police car, mistreated, and she had won a case at the High Court. And she was actually given not enough money, but some money because of the maltreatment by the police. We've also had a Supreme Court win in which a German-Mexican couple, so the Namibian-Mexican couple, and Digashu had won. Also, there were two different cases had sort of challenged that a child of theirs gets recognized as a Namibian citizen, which is a little bit hanging still. We also had a Supreme Court win in which foreign same-sex partners can now be domiciled in Namibia. However, what that has meant in terms of practice is that there has been a political pushback with us now facing 3 anti-gay marriage bills in Parliament in Namibia. The problem is not the anti-gay marriage bills that are in Parliament. The problem has been with the language that politicians have used in the parliamentary debates, which sometimes amounted to accusing the LGBT community of being satanic or being Satanists. What we have seen as a result of this language is unfortunately 8 gruesome murders of trans women and gay men from September of 2023 to about April of this year. The murders of gay men always bound up, gagged, and robbed, and with trans women found in riverbeds. The last one, so gruesome, although I wouldn't like to describe it, I will describe it so that people can actually really see what it means for a young trans woman to read in the paper that a 21-year-old trans woman was found in a riverbed with her genitalia cut off and put on her chest, which is really a hate crime that is undescribable, but a hate crime that we are linking to the language that politicians are using in Parliament under protected speech, and for which we as advocates cannot take them to court. And we also find, you're talking about the anti-gender movement, that not just in Namibia, but across Africa, there has been a pushback, not just for LGBT communities. We had a debate on abortion a year or two ago, and we found that there is a risk of rollback on women and contraception, definitely a rollback on women and their ability to choose whether to carry a pregnancy to term. There was a challenge on comprehensive sexuality education, and this is really important in our context because we have such a high level of teenage pregnancies and child marriages that we are trying to push back on, that we are trying to find answers for. And when young girls are not getting comprehensive sexuality education that is vetted within the curriculum of the schools, they don't have any idea of what their rights are, first and foremost, and how they can protect themselves. And so I think it is important, and at the moment we're also really seeing a shift in funding, for which I have to say thank you to the Global Fund, to the work that people like Christine and the parliamentarians are doing to always replenish the Global Fund, PEPFAR, because that is at the end what we rely on as local African LGBT to be able to do our work. We do not necessarily get government funding to do the work that we do. We rely on the Global Fund, we rely on PEPFAR, we rely on philanthropists, and this is the funding that makes magic for us and that keeps people safe. I'll kind of end there, and I would like to sort of just say that even though there is this pushback, even though people are being murdered, even though we have to keep on renewing our fight against the anti-rights, anti-gender movement for SRHR for women, for comprehensive sexuality education for young people, for LGBT rights, we have to keep on fighting, and we have to litigate when necessary. But that does not take away from the necessity of community engagement, speaking to traditional religious and community leaders, but also being at the policy table as equal partners to ensure that those policies are inclusive, the national strategic frameworks, and that adequate funding is given for the work that we do through the Global Fund, PEPFAR, and other funding sources.
Great, thank you very much. Thank you for grounding the topic in realities of people's lives. Tina, I know you had also spoken a little bit before the session started on the importance of language, which also came up in Friedel's presentation. Over to you.
Yes, so Hello, and I'm very pleased and honored to be here. And I was asked in advance to speak a little bit about German challenges and also the achievements here in German domestic policy, but also about Germany's global strategic. And maybe I will come to that point in advance, and I will start with that. Because if you may know, in the beginning of this term, 2021, something really great happened. Germany chose to implement feminist foreign policy as one of the core values when it comes to foreign policy. I know there are a lot of discussions about what feminism actually means. I tend to stick with the easiest definition. Feminism means that everyone, also women, also people from the LGBTQI community, have the same rights, and these rights have to be protected, and that we have to care for these rights, and that we have to care that people are having a seat on the table when it comes to decisions about their lives. But this was now 3 years ago, and as we already heard today, that on the international level there are upcoming debates about words. And there are states which which are taking combined efforts to erase words like gender or like feminism from legislations, from resolutions, even from titles of discussions, that they don't want to have these words sticking around. And I asked myself, because we also here in the German parliaments, I can tell you, when I negotiate with parliamentarians from other parties, sometimes these discussions also come up. They come up whether it's more important to have a word on a legislation, whether we talk about the word gender or feminism, feminist foreign policy, or whether the things which are embedded in the law and in the resolution are the things that matter. But language shapes the way we see the world and the way we see each other. And Friede, you gave us such a horrible and negative example how language can shape the way people think and how people act. And I think we have to put it in a positive way, that if we try to manage to keep the words, if we keep the word gender and feminist policy visible, then we also keep the people visible. And this is why I myself choose to take on the fight. And let's all make sure we keep every effort to not let go of these words, because it's not just words we would let go of, it's people and their visibility we would let go of. And this I think we should do everything we can that this shouldn't happen. Though I have to admit that I recognize that discussions are getting harder when it comes to that matters. There's also, and I have heard that argument like 10 or 20 years before, and it comes back, that it's a cultural thing. And that, especially when you come from Germany, you know, we are a country with a relatively good GDP, and we have a basic human rights approach I'm very proud of, but sometimes people try to twist it in a way that you shouldn't have a top-down approach to give these values to other countries which are not ready for it. This is like the usual explanations why something shouldn't happen. And I think it is really important that cultural feelings could never be a valid excuse for the violation of basic human rights. And that this is an argument we also have to keep in all the discussions, and which I'm proud that until now we managed, at least in Germany, to keep the feminist foreign policy in our policy strategy. But I also wanted to talk a little bit about concrete legislation and about concrete strategies here in Germany. And I'm very proud that this year in April we managed to pass a bill through the German parliament called the Self-Determination Law, which means that in future transgender, intersex and non-binary people will be able to have their gender entry in the civil register and also have their names changed in the passport by submitting only a declaration. If you remember, before that, it was that you have to undergo a very detailed and a very long-taking and a very psychological, exhausting procedure. You had to see doctors. You had to go in front of a committee, which for people felt like a court, that they had to explain their very identity just to get their names changed and just to be recognized as the people who they are. And I think with this law, with the self-determination law, we made it a lot easier for these people. And I think this was a good thing that we were actually able to pass that. We also have, since 2022, a Queer Rights Commissioner here in Germany, which is also a pretty cool thing. I mean, it's a person who can especially advocate for the rights of the people, and I think also this is also more a sign, and it's more it could be seen as a more symbolic gesture. I think this really means something for the people who he represents. I would like to mention the BIS 2030 strategy. BIS meaning something like until 2030, we have certain goals we want to achieve. And this strategy is about controlling HIV, hepatitis C and B, as well as STIs. And the important thing about this strategy is that it follows a need-based, integrated and cross-sectoral approach, which means that it is a certain aim, and we especially want to make sure that the need-based approach is fulfilled, and this includes access of preventive measures, testing, treatment, and it also includes that the people who are meant in this strategy have to sit on the table, and that we have to look at the core key needs, and that we have to focus on the key populations and not just talking about them. I also want to mention another good thing we achieved here, on my view as well, in the German public insurance. It is now possible to get HIV PrEP, so the pre-exposure prophylaxis. So it is covered, and it is funded by the whole society, if you want to make so. And I think this is also a sign that the whole society is willing and is contributing, that the health of the people who are relying on the PrEP is protected, even though that it costs money. And sometimes the discussions are about like, okay, rights are okay, we want to give people the rights, we want to give people the access, but if it costs money, then we will not do it. And regarding this example, we managed that also. We achieved the agreement that society, at least the public health insurance, where 90% of the populations are covered and 90% of the populations are also contributing financially, that this is covering the needs, and I think this is also a good thing. Germany tried to use the position as a chair of the program coordinating board of UNAIDS to increase the engagement towards addressing specific needs of key populations, and specifically transgender people in the HIV response, particularly when it comes to stigma and discrimination. I think this is also something we have to focus on in the future, and I think it is good to not let go of all these important things we will talk about today, and we also will talk about tomorrow. And I can just repeat what I think all people in this wonderful panel have stated before me, that when you're here in this room, I think something you acknowledge, and something which, I think you have already accepted, is that the struggle for visibility, for equal representation, for equal participation and gender equality is generally something that is continuously in need of our attention and our intense effort. It will not be over tomorrow. It will not be over the day after tomorrow. But I think, Friedel, if you are such a courageous example and such an outstanding man who achieved after so many years, and who fought for so many years to achieve this law and this win at the court, then I think we all can go on with the fight, and it will not give us a hard backlash if something sometimes goes in a negative direction, and if we have to fight for the rights and also for words when it comes to words in legislation. And I will go on doing so, and I hope that we all will keep on the fight.
So a wonderful set of interventions that really address the impact that this stuff is important. It's important in our health systems. It's important to individuals, and there are ways in which we can overcome them, but it does require ongoing concerted fighting. Oh my God. Okay. So I want to open it up for questions, both for the specifically for the panel, but also if you have interventions as well. This is supposed to be interactive. Can I try, if you can try and keep them short, because everyone is, lots of people are putting their hands up, and I will just be systematic. So if you've got the mic, if you can start from the back on my right-hand side and move forward, and then we will move to this side.
Thank you.
Thank you. Please introduce yourself.
I am Popras Aisu.
Yes.
I am a person with disability and a disability advocate. I come from Uganda. Inclusivity, leave no one behind. A woman plus a disability plus AIDS times other challenges equals rejection, exclusion. Now, my question is, where is disability? I want to ask the Ministry of Health, what are we doing to ensure that there is health equity on persons with disabilities so that we don't leave them behind? We are all potential candidates. Before you get there, what are we doing to prepare the way so that when you come, you find that the house is already organized? 2, we are all temporarily young or useful, but we are moving to the stage, if God gives us that will, then we shall end there as elderly. We need rehabilitation services for both persons with disabilities, for both elderly, and also other people. How can we make sure that we also have in the inclusive health, because it cannot be inclusive if certain aspects are left behind. So how are we going to ensure that in the health sector, we're also taking care of rehabilitation and assistive technology? Thank you.
Great. There was another hand up on that side. I'll come to this side.
Thank you. I'm Chris Lemov from Melbourne, Australia. My question is for Francis. Could you talk a bit about the links between the global north and the global south when it comes to the backlash and what is driving the discrimination against LGBTQ and reproductive rights, and therefore what people in the global north can do locally to affect the situation in low and middle income countries?
There was another question here.
Hello, everybody, and thank you for such a wonderful and interesting panel. I'm from the University of Vienna, the Data Solidarity team, and so I'm coming at this from the point of view of digital health, particularly with health data. And one thing that I would like to bring up, and maybe to hear your comments on, Pascal mentioned how health data from vulnerable communities can be suppressed, which is true. But on top of that, I would also add it's often not taken into account in the first place or even captured. And this can affect public health interventions and treatments. So I would be interested to hear any comments that you might have just on the issue specifically of health data as it pertains to vulnerable communities. So thank you very much.
Great, thank you. I'll take one more from that side, and then we'll move to the left-hand side.
Hi, I'm from Global Health 50/50, and my question is related to the two questions you already asked, so I'm very happy to make my question very concise. We publish global reports every year, which is about gender justice met in workplaces, especially on policies and the leadership level. And as a researcher of this organization, when I was collecting data on organizations, even if we are looking into gender, it was very hard to find gender-related data because data were all most likely related to sex, not gender. So I wanted to ask from you all, because I was very impressed by especially your talk about how important it is to talk about gender inclusivity and also the definition of gender. I wanted to ask for you all of how you are implementing data generation on gender, not sex, in your own organizations. Thank you.
Great. I'll take 3 from this side. There's a lady with glasses whose hand shot up even before the mics were available.
Thank you so much. So my name is Kana Halic Kordic, and I'm here on behalf of the International Federation of Medical Student Associations, IFMSA, as liaison officer for medical education issues. Firstly, I would like to thank you for sharing your valuable insights. So our organization, IFMSA, actually conducted a survey that revealed that over 50% of students that responded to the survey reported that they are lacking educators that have competences in equity, diversity, and inclusion, and also that there is lack of accessibility when it comes to resources for equity and diversity and inclusion in medical education and healthcare. We as Federation believe that equity, diversity, and inclusion skills are necessity in order to create inclusive healthcare systems. So in light of that, our question would be if you could reflect and propose some recommendations that we can have to address these challenges and how we can collaborate on international, national, and local level to make sure that future healthcare professionals are equipped with equity, diversity, and inclusion skills. Thank you.
Great, thank you. There was another, yes, next to you. Just hand the mic over.
Hello, this is Sukhada. I work with a consulting firm called Seek Development based in Berlin, but I'm from India. My question is on the point that Friedel mentioned about bringing community together to be able to make a change. The question is around what are the efforts that governments both in federal states like Germany and even LMIC is taking to have interventions that are community-based, but around the fact of breaking stigma around alternate genders. There is a lack of representation of these genders, but there is also a lot of stigma around it. So would like to hear your thoughts on the efforts around it.
And in front.
Hi, my name is Peter. I work here for Action Against AIDS in Germany. I have a question to you, Frieder. You said that you mentioned that homosexuality as a Western import, and I watched closely the situation in Uganda the recent years, and I've noticed that Family Health International, which is an American NGO, and some radical religious groups coming from America are supporting these hate laws extensively. So my question to you is, did something like this happen in your country? Thanks.
Great. And did you have any other hands up on this side? Okay, so panelists. I have a question on disability and ensuring disability is part of the agenda. One on global north, global south backlash, how similar or different it is. The impact of or the role of digital data and disaggregation. The DEI educators as critical to training of the future workforce and the impact of community, and some further engagement around for further details on the role of the very wealthy anti-rights movement and their penetration in low and middle income countries. So pick any or all of these as you want. Tina, if I can start with you this time.
Yes, I will start with the first question regarding disability and intersectionality of discrimination, if I understood correctly. And I think what we all can do is addressing this topic on a broader level. I think there also are recommendations, and I think also WHO has to make sure that this is constantly on the agenda. But I want to be more specific, and I think that the actual challenge lies within the national health systems itself. And I think it is a good aim that every health system needs some kind of action plan. We in Germany also haven't had one so far, but we are trying to get one. It was one of the aims for this term, and we started 2 years ago. And in this action plan for inclusivity and barrier-free health systems, we also tried to include the people with disability, different groups. So it was a long process of consulting these groups, and I think this is how it should be done. So yes, you have to manage that this is a priority of your own health system, and that you can implement a process where everybody comes at the table whose views are important. And I hope that this could be an example which you could maybe suggest in other circumstances in other countries where this also could be a good idea to ask for such an action plan in the health system. I also want to pick the question about the medical curricula. And I think also this is a question of how can you make sure that there are curricula for the different universities, which I think you all know that universities are like they are inherent places of where professors used to speak about whatever they wanted. And just now we are having the discussions about also something which should be in the curricula. And when it comes to the topics you were talking about, like equity, inclusivity, diversity, then at least for us in Germany, I also can say it was a long discussion, but we are just one moment before getting the next step of having this curriculum, which we also have been talking for like 10 years. But at least after that period of time, I think this is also a success that we were able to implement this. And I also want to pick your question. If I understood correctly, it was basically about visibility of people. And I cannot give you a correct answer. I can just give you an example. In my constituency, in my district in Thuringia, which is also more like, it's more conservative as Berlin, if you want to say so. And in this year's election for the federal parliament, we had such a great transgender candidate. And she decided to pull out of the race just 2 months before the election. And this was due to enormous pressure from far right-wing, but also very conservative press and attacks. And I think you can imagine what she had to go through. And the thing I asked myself afterwards was, I mean, when she told us, then the decision was already made. And I wished that I would have known it before. And I wished that we would have maybe the chance to give her more support and give her something that she would have needed to stay in the race. And it's always the person themselves who have to make the decision to run, to get the visibility and to stick out for themselves in everyday situations. But I think it's also us to support that. And I, for myself, would wish that we also can take more of these opportunities to show our support and to support them to take the visibility.
Thank you. Friedel, I think you had quite a few of the questions, so I will go to Christine first, and then come to you to wrap up that round before we go back.
Yeah, thank you. And thank you for all the questions. I think I want to answer the question on data, maybe in not such an exciting way. But, you know, the first part about data, and that's one of the roles I think we play at the UN, is that we are asking member states to report. And even by just asking, can you report services available for transgender people, for men who have sex with men in our case, for sex workers or for drug users, it puts them on the spot to actually answer the question of whether or not they're actually even looking and accepting that there are these populations. And we are asking them within the context of health, right? It's an easier question to ask in this context. And when you go on our website, you will see we have these reporting cards for, it has to do with prevention, but it's quite, it is quite frustrating to see year after year how on certain populations there is no report. So the member states just put in no data available. But they are making a political commitment to end HIV in their communities. And they know, in many cases, these are the communities most affected, but they still answer with saying no data. So then the next question becomes, when they answer like that, what do we do? You know, what is our ability to hold them accountable and say, well, if you keep on saying no answer or no data, there needs to be some kind of consequence for that. And often the answer is, well, we can't find them, we don't know how to count them, it's all of that, and there's a technical response to it, but often it's more of a political response that is needed, and a bit of more political arm twisting, if you may say that. That's needed. So that's one thing. But I think data is really important in other ways. So, for example, and I know the question was for Frida, but when you were asking the question of, or Peter, you were asking the question about funding streams and can we connect what's happening in the global north and in the global south, and then it's being turned around on us and said, well, homosexuality is a colonial construct or an import. When we know that the funding that funds some of this comes from sources in the global north. And I think there's really important that we also create data. We need to show, and we need to keep on making it public what these funding streams are, to dispel the myth that, this is homegrown. I often find it quite interesting how churches, especially Christian churches, tell us that it's not African, as if Christianity kind of fell from the sky onto these communities. So I think it is within all of our gift, often not within the UN, but it is civil society that needs to keep on providing the data to show these are the funding streams, this is what happened, this is where the influence comes from, so that we can start communicating in a different way. I know evidence is not always what helps us to make our arguments, even though we pretend sometimes that if we have the right arguments, people will change. So I think that's really important. I wanted to also say something about backlash. And I think that's something that we're all experiencing, and it's almost because we have come a long way. And I think Pascal's very insightful opening remarks speak to that. This long way of challenging certain things and making sure that comprehensive sexuality education is in all schools for all people, that we name different groups, that we are trying to be inclusive, and that we are successful in the courts. And what we are now experiencing is a backlash. And I think we're not spending enough time really thinking about how we're responding to that. Instead, what's happening increasingly, and I think that's partly because of funding streams, we're self-censoring. So we're starting, and Pascal and me know this very well, because even in the UN, we start saying, should we talk about sexual and reproductive health and rights? Or do we leave out the last R because it's maybe a bit complicated right now? And there's something there that we could do better to try and ensure that we are not self-censoring, and so we are losing the gains that we have found now. One of the things that I was going to say that I think is really important, and I can't remember how it started, is this thing that we don't make it's a problem in one part of the world and not in another part of the world. And so I think increasingly having partnerships, so we have a global partnership to eliminate all stigma and discrimination with regard to HIV. Initially, it was only countries from the global south who were part of it. So about 30 countries. They all committed to doing certain things in healthcare settings, in community settings, to look at stigma and discrimination and to do certain things and how to bring communities to the table and so forth. But increasingly, we're having countries in the global north joining the partnership, and that provides a level playing field to say, you know what, we still have areas that we struggle with, for example, discrimination in the healthcare setting or gender equality in some countries. So Germany just recently joined it, and the chancellor announced it at the AIDS conference, which is for me is a really positive step for countries to say we all experiencing these challenges against gender equality, against diverse sexualities, and this is one way of bringing them out, and bringing them out in a joint effort with countries in the global south to say there is stuff that levels us up. We all experiencing similar challenges. So for Europe, it's now Germany, Spain, and Luxembourg who are part of it. And I think that's a good bit of our work that brings us together in a more equal way, acknowledging that there are challenges for all of us. The feminist foreign policy was established by so many countries, and we already see in countries in Europe taking it off the table again. Sweden is a good example for that, right? Why is that happening? And so kind of not making it's a their problem, it's a not us problem, but really thinking about what are our collective problems together and how do we solve them together.
Great. Thank you very much, Christine. Fredo.
Thanks. Thank you. Got a lot of questions, so I'll start with disability, I guess, and talk about the Namibian experience. Because what we had found, we work in an intersectional, we've had to set up intersectional networks at community level. In Namibia specifically, the problem has been that the issue of disability has been owned by government, and so they created a desk within the ministry, which I'm not sure if it is a good thing or a bad thing, but I think there has been a loss of community voice, and so you kind of see a lot of what would be developments in hotels that we're having that don't have ramps, etc., not being done because it's almost like they've been swallowed up in government structures and in government bureaucracy and lost their voice. We still try and reach out to them to kind of have a community voice. I'll leave it at that. In terms of data, it's really a big challenge because we can't advocate without data. We can't speak without data, and I really like the issue of telehealth and digital health. At the moment, we're kind of starting to think about it because the security situation is really, really becoming a little bit treacherous, and we know that we can reach people who are really scared if they're able to call and get a prescription, or if they're able to call and speak to a doctor. And so I hope that continues, because we would need for marginalized populations more telehealth, more digital health, because it sort of cuts them getting on the streets, going to a health center, especially when emergencies are high. I know that in my job I've had to move a lot of trans people from their homes, but because of funding, maybe for a week, maybe for 2 weeks, and then they have to be back again in the same situation. But for trans women on hormones, it really becomes difficult because many of them had to kind of cut their hormones. Some of them who have been on HIV treatment had to cut their HIV treatment. And we always try and find a solution to keep them on treatment. And we don't always reach all of them, but those we don't reach, maybe with telehealth, we can reach, and maybe that way we can also get data that we can use to advocate for. I'd like to address the question more of the anti-gender, anti-rights movement, because because of my job as a safety and security coordinator at the moment, I was lucky to get a little bit more information and data on it. And at the moment, because Namibia is going to go into elections in November of this year, we are kind of really working very hard on pre-banking the messages from the anti-gender movement. Like I said before, we've already had attempts to roll back on abortion rights or to stop abortion rights because it was really going to move forward and make abortion a possibility for all women, and we are kind of stuck in the same place. We were able to save comprehensive sexuality education, but what we've kind of found is that both the global north and the global south are really at a precipitous point where we really need to understand where this anti-gender movement comes from, and like Christine was saying, how they are funded. I think that we are lucky that we now have their policies written out in Project 2025. Because it used to be very nebulous and we didn't understand where it's coming from and how it's working. But we do know that there is a real risk come 2025 that in the US, for example, women will not have mail-in contraceptives anymore because of an old law that will be revived and which will stop women from having these contraceptives posted to them. We also know that African spirituality has for a long time, I think we are working with an American-based organization now called Connecting Consciousness, who've been doing the research on that. And that the idea is very old. It comes from 1405, I think, with a pope telling the king of Portugal to go on this exploring the world, but that also went along with this Christianity, a specific type of Christianity that was exported, and that these ideas have now been refined. We know that the anti-gender movement funds go to Pentecostal churches and that they cozy up local politicians, and that when you look at the laws, for example, the Uganda law, the Ghana law, the Nigeria law, and the laws in Namibia, that they are model laws. The language has changed slightly, but when you look at the law itself, it's the same thing that goes from the one country to the other country and to the other country. We also understand why, that if us as Africans are fighting among each other about homosexuality or women's rights and power given to women or homosexuals taking up space, that kind of gives us room to divert away from the question of development. That diverts our attention away from equity and equitable negotiations with international companies that come to Africa to extract, and that they can continue to extract. And so I think we now have opportunities to work with the Global North, with like-minded organizations, to find messages and to pre-bank messages already. We now have a language that we can speak to with the Pan-Africanist youth movement so that they understand where these ideas come from. And when we have that conversation, hopefully we are going to end up at a place where we have a different kind of consciousness about the anti-gender, anti-rights movement, who have kind of, without us really understanding where it was coming from and where it is going, have kind of brought in messages about homosexuality being un-African, for example. We are now able to respond to that, and we are going to keep on doing that. I'm not sure if I'm answering all the questions properly. There was one that I wanted to take up about healthcare workers around equity, diversity, and justice. And our example of what we've tried to do is to shortcut the bureaucracy of policy, and luckily through the funding from Global Fund, from PEPFAR and other international partners, and obviously a policy change in the national strategic framework, we have been able to get civil society organizations to go and do pre-service and in-service training of nurses and clinicians. And so what we have done is to get sex workers to speak as sex workers to doctors in training, gay men and lesbian women and other LGBT groups to speak as themselves to doctors and nurses in training, so that we are able to kind of reach a target of a competent service, a population competent service. I think it is important to write it into curricula, and that we are still working towards it. But it's also important for clinicians to be exposed to and speak directly to gay men, to lesbian women, to trans people, to sex workers, to people who use and inject drugs, so that they're able to understand their issues on a human, personal level, and so that when they meet these people at health centers, they're able to understand what their needs are and use their clinical knowledge and human understanding to provide a friendly and competent service to them. And finally, efforts on the ground from EU partners, it's a problem. The funding, I think when we're talking about health funding, it sometimes becomes really difficult to use that for other means, such as community engagement. It's a fight that we always have to have. I think it's a fight that we always have with our EU delegation in Namibia, for example, or with PEPFAR, to say how can funding be a little bit more flexible so that it doesn't just address clinical outcomes or improve clinical outcomes, but also community-based needs of populations. And I hope that if you are in this room and you have access to EU partners, to PEPFAR, to Global Fund, to keep continuing raising those messages that we do need flexible funding, because we don't just experience our lives or the need for improved clinical outcomes in facilities, and that much of the action to improve outcomes happens in communities.
Great. Thank you very much for that. I think we're now getting into kind of the deep dive complications of this issue. I mean, if I were to try and simplify the message, it's like treat everybody like human beings. We're all equal, right?
Or how you would like to be treated
or
yourself.
how you would like to be treated yourself. So it shouldn't be this hard to be able to do this, but it is. I mean, as we've gone through the various questions, the various interventions, and the questions, you can all see that it becomes these issues, regardless of the fact that all member states have said we leave no one behind, and therefore that means we need to explore these issues of inequities within our communities and address them. These issues are now very much used as the political wedge issues within domestic political processes across the. I mean, it is within the UN space. It's really disheartening to see the literally when we talk about negotiations, the which country give up on this language and we'll give you this bit and it really is a bit like horse trading, and without a real sense that this has impact on real people's lives. Some of the hopeful, we have heard some very hopeful messaging as part of this. I think one of the bits that I really want to pick up on is the importance of accountability and placing accountability mechanisms at all levels, whether we're working through communities and so on. How do we hold each other accountable? How do we hold our duty bearers accountable, and to make sure that we go ahead and fulfill these the promises that have been made. I do want to, we are coming close to time. If you had, my sense, I was in a meeting previously where it says we have to be hopeful, everybody has to have hope, and hope is important. Hope is what drives us. But what more than that, we need courage. We need the activists, we need to keep pushing. Unfortunately, we do need to keep this on our agendas. We do need to put energy and so on into it. So we need the courage as well. Christine, one sentence or less, maybe a few words.
Unlike me.
What is your message of hope?
You know, I don't know if it's a message of hope, but I actually wanted to say something that you spoke about. This issue about ultimately all of this comes back to very simple principles that are in the Universal Declaration on Human Rights. And sometimes I feel like instead of making it so complicated, is that we need a set of very simple messages that just keep on reminding people. We do have a challenge that now we're even questioned about that. And people saying, well, when we ratified the Universal Declaration of Human Rights, we weren't all there because, let's be honest, half of the world was still colonized at the time. So there is an argument to that. But it's almost coming back to a place of basics, of saying we have a compact amongst member states, all of us, who have said, unless we change this, that this is what we all agree on. It's a very simple message around inclusivity, and that goes across all the sectors and all the groups. But I feel like we have muddled ourselves in so many side conversations that simple message of that there was a point after the Second World War where we all agreed all human lives are equal, we're all equal before the law, we are all equal when it comes to the the universality and connectivity of all the human rights that we all agreed on. And I feel like sometimes that's the basic bit that we need to come back to.
Thank you. That was a few more than one sentence.
I told you,
we'll let it ride. Fredo.
Yeah. Also, I mean, in a previous panel, somebody said that health is not something that has boundaries. So Germany. So my message would be, we've learned messages from the HIV epidemic, so many epidemics that we're confronting, even COVID, that epidemics don't know boundaries. Health is something that we share as a humanity, and perhaps even more than humanity, as a planet. And so I think the message that we always need to have and remind people is that if we exclude someone, if we exclude a country, if we exclude a geography, a population, it is bound to come back to us. We may pretend that they don't exist, but we'll soon find that the problem that we've been trying to exclude then comes back to the populations that we care for and we say are our own. And so I think born out of experience and data and learnings from the past, that for global health, we need to include, not because we like it, but because it's an imperative.
Thank you. Tina.
Yeah, actually, I cannot add much, but maybe I can make a synthesis out of what you two said, and I would frame it like that. Hope is good, but as you said, we also need courage, and we have to go both ways in our argumentations. We have to always held up the human rights-based approach, which you should label as the altruistic approach. We want that people feel safe. We want that people can fulfill their lives and have access to health. But we also have to acknowledge that maybe for some years, maybe for some time, we will also have to argue with the egoistic approach. And this comes back to what you said, that it's also in our very own interest. And this is, it means regarding every country that we have to guarantee certain rights, because these rights are one of the necessities when it comes to access to health. And I don't want to go into detail. I think there were a lot of examples for that.
Thank you very
much. Let's stick to both argumentations.
So can I end by saying a very big thank you to the Ministry for hosting this session. And just a few final words. We speak of goals, of hopes, of dreams, of healthier worlds and shining gleams. But in the shadows, voices cry, ignored beneath the same blue sky. We say, leave no one behind, yet still we turn our backs, deny the will. For health and gender, justice calls, but silence echoes through the walls. If we do not include the weak, the ones who tremble when they speak, if borders blind us to their fight, then we will never make it right. Equality cannot survive if only few are kept alive. For health to truly light the way, each voice must have a rightful say. The goals we chase, the dreams we weave, will fall apart if we deceive ourselves, the world, the truth we know. Without inclusion, we will not grow. So let us listen, let us see that in their cries our hope must be. Without their strength, without their grace, we will not win this urgent race. Can we give a big round of applause to our panel? Thank you for joining us. Thank you all for coming to WHS, and safe travels back home. Please drop me a line.
Thanks, Pascal. Let me just also close the session officially, since we've invited. So on behalf of the Ministry of Health, let me thank all the panelists for being here today and for your time and contribution. Of course, Pascal, for your excellent moderation of the session. And let me also explain something that I wanted to say in the beginning, because one panelist is missing. You might have expected the Minister of Health of Malawi. She couldn't attend, so she sends her regrets. But I should have said that in the beginning, because there were 3 panelists when you might have expected 4. Thank you so much for this excellent session, and safe travels back.